will call on Ontario Health Coalition. You will have 7 minutes for your presentation. Please state your name for Hansard and you may begin. Thank you.
Thank you. My name is Natalie Mehra, and I'm the Executive Director of the Ontario Health Coalition. Bill 175 amends or repeals at least 11 other acts that have been passed by the legislature. And we are extremely concerned because what it will result in is the wholesale restructuring of home and community care from bottom to top. It also, through the regulations, reaches beyond home and community care to establish a new tier of congregate residential care, unlicensed. It also, in the regulations, reaches beyond home and community care to cover home care delivered by private companies in public hospitals. And in the legislation itself, it reaches beyond home and community care into private hospitals as well. This legislation is so misguided in its conception and so flawed in its execution that we're taking the unusual step of calling for it to be entirely withdrawn. We are appalled that the government would move forward with this legislation to wholesale restructure home care and hospital and congregate care and private hospital care in fundamental ways in the middle of a pandemic. The main thing that this bill does is that it repeals the Home and Community Services Act. And in so doing, it guts all of the public interest protections that exist in that act. In the summary regulation package, which is not even the actual regulations that are drafted, it's a summary of what might be drafted down the road. It proposes to move some of and possibly change some of these provisions, and then a number of other provisions are just not there at all. Among the ones that have been removed from the Act with the repeal of the Act, the definitions of the actual services to be covered, the Bill of Rights for clients in home care, requirements of the provider agency such as the development of a plan of service in accordance with regulations, rules, and standards, provision of a service within a reasonable time frame, requirement to put people on a wait list if that service is not readily available, prohibition of charges for professional or personal support services in accordance with the plan of care. Those are vital public interest protections. To be entirely removed and not mentioned in the regulations, the ability for the minister to enforce the Bill of Rights through the minister's ability to approve or disapprove of agencies who do not comply with the Bill of Rights. That similar power for the minister is removed with regards to ensuring that the agencies are financially capable of providing the service. A similar provision removed with regards of the ability of the minister to assure that the agency provides services with competence, honesty, integrity, concern for the health, safety, and well-being of the persons receiving the service. All of that is removed. Similar provision regarding the minister's ability to not approve agencies where the premises are not suitable for the provision of community care services. Currently, the minister may impose terms and conditions on financial assistance. That's removed. The requirements of the provider agencies to be removed, public filing of records, notice to clients in writing of the Bill of Rights, the name of the service provider, procedures for making complaints, how to request a record, where the client can access the services accountability agreements, a plan for preventing abuse, including physical, mental, and financial abuse. These are vital public interest protections. They belong in legislation. As the committee knows, when something's in regulation, it can be changed by cabinet without ever going back to the legislature for a vote. In this way, this bill takes us back more than 25 years in terms of the development of public interest protections in home care. In addition to the gutting of the existing home and community care legislation, in the regulations, this bill sets up an entirely new system of providing home care that is not actually a system. It would fragment home care into thousands of different potential permutations and machinations around Ontario. It takes the funding part of the LHINs, which is the LHINs are currently Crown agencies, they're fully public. It siphons that off to Ontario Health. Previous presenter Larry and Helen already talked about Ontario Health. The board is dominated by bankers, private financial interests, real estate investment trusts, private long-term care industry, and so on. There is no normal public governance protections for Ontario Health. There are no open board meetings, no minutes, no access to information, etc. Then the powers to do placement coordination and care coordination, vital public functions that are currently public, would be siphoned off themselves to a set of middlemen companies, including
2
the Ontario
minutes.
Health teams. Sorry, what was that?
2 minutes.
Including the Ontario Health teams, which are loose coalitions of for-profit and not-for-profit companies with no governance whatsoever, no boards of directors for the OHTs, no public governance norms, no protection for the public interest whatsoever. Primary healthcare providers, including the whole array of private for-profit primary healthcare providers, nonprofits or other third parties. They would then be able to take care coordination and contracted and subcontracted and the other direct care provision services to private for-profit or not-for-profit care companies. This change is significant, and it means that vital parts of home care would be privatized and put into the control of companies that often have conflicts of interest. It would be chaotic. It means that the structures emerging for home care and community care across the province
1
will vary
minute.
dramatically from place to place. And it would create a conflict of interest in which for-profit companies can both do care coordination and provide the care itself, therefore deciding how many supplies people get, how much care they get, and profiting from that service. It would also send privatized care into public hospitals, and in the Act itself, it allows private hospitals to expand into a new tier of unregulated, unlicensed, congregate care, which is set up in the regulation, as if we have learned nothing from the appalling record of the spread of COVID-19 in congregate care settings. For all of these reasons, we find this bill to be fatally flawed. We are extremely disturbed at the process, and we're calling for the government to withdraw it and to undertake a proper consultation process that is democratic, that does not just include provider companies to reform healthcare in their interests, but actually operates in the public interest. Thank you.
Thank you very much for the presentation. We are now going to go to the government side first for the questions. MPP Martin.
Thank you so much, Chair, and thank you very much to the presenters for coming today and for giving us their thoughts on the bill. This is a very important piece of legislation. It is about modernizing the home and community care sector, and we think that that is critical. The current legislation, of course, is over 25 years old and does not reflect the realities of today, and really has a siloed approach to care, creating barriers, frankly, to address client and caregiver needs. And that's why the current system that we're under, I don't think anyone thinks is working very well. And so we need to change it. And that's what the whole intent of this legislation is about. We've put forward legislation which is enabling legislation, and we're trying very hard to make sure that we do not disrupt the important care that people are receiving in the interim, because we want to make sure that there's a continuity of care for people who are looking for home care services and community care services, because we know how important those are to them. So the legislation has some goals, including making it easier for people to access home and community care, connecting with their care providers, and we have noted that home and community care provision can be an isolating experience for the people providing that care and for the people receiving it, frankly. And so we want them to be more connected to their other healthcare providers. And part of what this enables is virtual connections, which should have happened a long time ago. So a PSW would be able to provide input into what they've noticed about the care of the patient that they're looking after to the other healthcare providers. We also want to provide more choice for people with high care needs so that they can get into new community settings. And we want to keep people healthier and keep them at home. And I think I was listening to what Larry had to say in his presentation, and I noted that he said that he wanted good community care, and that it could be part of the solution to hallway health care, that he wanted to make sure that our elders have a better quality of life, and that they could remain in their own homes. They prefer to do that, and that the focus should be on the patient. I took that down as well, that Larry had said that. And so I agree, Larry, those are what the bill is intending to get us to, and we're trying to find this model of integrated care. So that's where we're headed. The legislation is about breaking down those bureaucratic barriers, and our Ontario health teams will work in partnership with home and community care service providers, to provide a flexible, innovative, integrative delivery model, including care coordination. And home care services will be delivered as they are now, without patient co-payments, if that's the way they're delivered now. And the Connecting Care People to Home and Community Care Act, if passed, and the proposed regulations make that clear, actually. And by the way, the regulations were put forward on the, when we tabled the bill, the regulations were posted, or summaries of the regulations were posted on the regulatory registry for public comment for a 60-day period. So there is, of course, a way to input into regulations when those are changed, and that's a very important aspect of it. And we have received submissions from people on the regulations, and are taking that into account as we go forward and develop them further. So there's a lot of other things I could talk about. One thing is the public consultation that we've had. We've had through our Premier's Council on Improving Healthcare and Ending Hallway Healthcare, and through the Minister's own consultations on various healthcare issues. And Bill 175, of course, has been debated in the legislature and will continue to be. And our regulations were posted, as I said, for 60 days for public comment, and were taken down in on April 14th. So we're working very hard to make sure that this legislation is a solution to our problems in home and community care. We'd like to
2 minutes.
we'd like to see some changes. And I want to just address the privatization concern. There are no provisions in this legislation that are aimed at privatizing health care in general or home or community care, although we did have an earlier presenter who said this is a disingenuous debate that does not serve patients well, and we shouldn't be talking about whether it's private or public. We should be talking about whether the patient is at the center, and I firmly agree with that. And I think we get buried in this conversation and we forget about the patient. So I guess I just wanted to ask Larry, do you believe that the most important priority, Larry, in reforming home care, and I know your daughter was a PSW, is that the patient and the care and outcomes for the patient? Do you agree with that, yes or no?
Larry, you are on mute.
Mute. Okay. Am I on? Okay.
Yeah.
To say yes or no, probably.
And 1 minute.
Simple. I agree, but you've got to recognize there's far more to the question.
Well, I agree, Larry. I just wanted to ask you that question, yes or no. Let me ask you another question. Your daughter was a PSW, and she stopped being a PSW and is now a cashier. That's what you said.
Correct.
That is a loss to the system. We want to keep PSWs working in the system. So do you think that some of the changes proposed will help PSWs to be taken more seriously by other care providers? For example, virtual connection with the doctor, so that their opinion about what's happening with the patient could also be considered. And I've been told by many PSWs that they don't feel their opinions are respected. What do you think, Larry? Do you think that would be helpful?
No, I mean, actually, I'm going to have
Sorry to cut you off. My apologies. We are now going to move to the independent member, MPP Fraser. Please go ahead.
Thank you very much, Chair. And I'm going to ask, the question I'm going to ask is going to be for everybody in sequence of their presentation. But before I get to the question, I just want to say that this whole idea of public and private and having this debate is very clear that the legislation is permissive and open in that regard. It's allowing for things to happen, and there are some serious questions right now about the provision of care. and what's happened as we see in long-term care and as we see with employees, PSWs, people who are serving in home care. So I think they're legitimate questions. The thing that really troubles me is that we're removing accountability and governance, not just from the public, but from ourselves. And no matter where you stand on what you think should be inside this box, to actually abdicate the legislative pieces that enable us as members to be able to take action and do things on behalf of our constituents, making sure that that structure around this thing is really critical. So it's not an academic debate. We have a responsibility, and what I'm trying to express, and I don't think anybody in this room wants care not to be the best care. We're all in the same spot. It's how we actually ensure that on an ongoing basis. And I've sat on both sides of the table. That's what I'm trying to express, and that's why I'm asking this question. In particular right now, I'm very concerned about the Consumer Bill of Rights, Patient Bill of Rights, being pulled out and put into regulations. Because I think it's something that we should decide as a legislature is the right thing to do. We did that in 1994. It lasted this long. It needs to be updated. So to all the presenters, do you agree with that it should be in legislation? Do you think that we should actually look at that Patient Consumer Bill of Rights in a more broader sense to look at what we have to update? And on top of that, is there anything that you think that we should add to that Patient Bill of Rights? So that's for everybody. You can start with...
we can start with uniform.
Uniform, okay?
Yes. Larry, please go ahead.
Okay. Yes, I agree that the Bill of Rights needs to be in regulation. I think that's pretty simple. And there needs to be some oversight as to what is happening generally. The one thing I mentioned earlier that I think is missing here is we've got a significant number of members that are not on the internet. So when you talk about visual somehow doing something, that's a problem. And I'm not sure how you get around it.
So my question is, you said it should be in regulation or legislation?
Yes.
Did you mean?
Sorry, it should be in legislation, okay, not regulation. Sorry if I wasn't clear.
Thank you. Sorry.
We'll go with the Communist Party. Helen?
Yes, I believe that there should be a Bill of Rights. It shouldn't be in this bill, in legislation. It shouldn't be in this legislation because this legislation is so bad. And I think that beyond just a Bill of Rights for patients and clients, we need to have a home and community care legislation that actually embraces human rights. And this does not embrace human rights for those PSWs who are making the lowest wages in the sector without sick time, without benefits, without a livable wage. And that has to be addressed. And we've seen a huge marches in the streets. They're marching for, the elimination of systemic racism. And this government can do it with this piece of legislation. Not this piece, but a piece that will addresses the restructuring of home and community care to respect the human rights of PSWs.
Thank you.
Next is Ontario Health.
Thank you. So to the members' comments, the legislation actually goes beyond being permissive on privatization. The last section on the Private Hospitals Act, Section 9,
2 minutes.
subsection 9, sorry?
2 minutes.
Subsection 9 changes the definition section of the Private Hospitals Act to enable private hospitals to expand into this new congregate care section. That would, for the first time since the inception of the public hospital system in Ontario, allow private for-profit hospitals to expand. So it actually goes beyond being permissive. In terms of the regulations, it expressly describes a system in which most of the existing public functions in home care would be privatized. In terms of the Bill of Rights, it absolutely should be in the legislation. It needs to be modernized. The diversity section is out of date and needs to be modernized. In addition, patients need to have a positive right to access home care. So there's actually a floor. And if they can't access the service, then they have to be put on a wait list. So there's some measure of how many people
1 minute.
can't access the service. Currently, people, LHINs have just cut off everyone who has moderate care needs or below because of funding constraints. The CAPS issue is irrelevant because when you don't have enough funding, you just can't provide the care. In addition, there need to be other protections, including fundamentally protections against abuse, which are now pulled out of the Act. That's shocking. And the complaints process. People need to be able to make meaningful complaints, have them answered in writing, have a process to do that. This bill sets it up so that you would have to complain to the provider company itself. Good luck to you in getting anything addressed in that way. I mean, we already see the problem of that. And in terms of the whole system here, I mean, what this act does is hand over and the regulations together, and they're a 1-2 punch. The act completely guts the existing legislation. Everything is moved into the regulations, and respectfully to the member who
Thank you
just
very
spoke,
much. Apologies to cut you off. Now we are going to move to the opposition side. MPP Teresa Armstrong. She's on the phone. Go ahead, please.
To let the Ontario Health Coalition finish her remarks, please.
Helen, go ahead. Sorry, Natalie.
thank you.
Health Coalition was the last person to speak.
Yeah, Natalie, please go ahead. Sorry, my apologies.
Okay, thank you. Sorry, I'll just be quick. So with respect to the first member who asked questions from the governing party, in her comments, she said that sorry, I've just lost my train of thought for a second. I'm sorry, I've just lost it. Sorry.
I appreciate your comments very much to all the presenters. Thank you. I strongly disagree, I think, with not having a debate between public and private. I think that has to be on the table when we're talking about healthcare, because anytime public money is going into private hands, they're squeezing dollars out for profits, and that takes away from the frontline care for patients. So I respectfully disagree with my colleagues around the table. This is not a debate about public or profit. We know that we've had the long-term care home situation clearly indicate that when there's not the proper inspections and oversight, things get buried. And thank goodness for the Canadian military exposing those things. No one in that system has ever come forward and publicly addressed the egregious acts that were happening. There have been reports and after reports, and governments have ignored them. So I just want to ask the question to the Ontario Health Coalition to just maybe to expand a little bit or on the conflict of interest and how detrimental that can be to public health care. For the Ontario Health Coalition. Hello?
Thank you. Sorry, I had to wait to unmute. Thank you for that. Sorry, I did remember, and the government speaker said that the regulations were posted, but I just wanted to clarify a summary of the proposed regulations in 2 appendixes, not the actual regulations, were posted with almost no one even received the notice. It was during the pandemic. On the question of elaborating on the conflict of interest, in this legislation, the funding would be given to Ontario Health, the board of which is dominated by for-profit companies. The placement coordination, so the LHINs currently provide placement coordination, direct care in terms of school visiting nurses, some direct PSW nursing, health professionals care where there are contracted companies providing it, and then also vitally the care coordination function. In the new act, the care coordination function and apparently the placement coordination functions would be hived off to an array of provider companies who can then themselves provide the services, who would then subcontract care coordination on right through to the direct provision of service. So if you're providing care coordination and you're determining whether or not someone can access a service, how much of that service, how many supplies, and so on, and then also providing that service. And there's no oversight, there's no governing body. The LHINs are gone, the CCACs are gone. There is no public body providing any oversight whatsoever. Your company is the only place that patients can go to complain to about any of this stuff. And you're a for-profit company that has an interest in pulling as much money out for profit as possible. And if you're a for-profit chain, you have an interest or company in gaining as much market share as possible. That is a conflict of interest. And there are no protections, none, in the legislation and in the regulations, such as they have been, proposed. A summary has been proposed to provide for any protections whatsoever. And they set up expressly this conflict of interest.
My colleague Franz Julena has a question.
Okay, Madame Jolena, please go ahead.
Thank you. Not much time left.
You only have 2 minutes.
I want to start by telling all three presenters that it's not because an MPP asks you a yes or no answer that you have to provide this. You didn't do anything wrong. You don't have to answer questions that you don't want to answer, no matter if they're rude, if they're shouted at you, or whatever else. You answer question the way you want to. And we're happy to hear from you. So my questions to you has to do with the standards. You come from different parts of the province. Are you able to talk about the needs to have a standard of care that would apply to all regions of the province? I will start with Larry, then Helen, then Natalie, if we can all be brief.
I'll try to be brief. I'm familiar with the Waterloo region, so I'm not sure how far that would go across the province.
1 minute.
I think especially in the rural areas, it probably would be more of a problem, and I'm not quite sure what you do there. There is no easy answer to this question, but I think there's got to be some general discussion about how to deal with it.
Would you agree that we do need a standard of care, that no matter where you live, the care should meet your needs?
We need something that is significant, that's a minimum standard for anybody that needs care.
Thank you. Mrs. Kennedy?
I'd rather talk about a maximum level of care. I think that, it should be all home and community care should be at a community level, not at a huge LHIN level where people are traveling all over the place. So I think that that's what I would say.
Okay, Mrs. Mehra?
I didn't hear that.
Yeah, absolutely. We agree that there should be a host of clear standards regarding care.
Thank you so much. Apologies to cut you off. For this round, we're going to go to the independent member, MPP Fraser, and he is saying that, Natalie, you can continue your thoughts.
Thank you very much. So we agree there should be a standard around access to care that says that clients, so people who require home and community care services, should be able to get the services based on their assessed need for those services. And if they can't get them immediately because they're not available, they should be waitlisted, which is why, so at least there's a way to measure how many people are not able to access care and how insufficient the care is. Currently, that does not, currently that is required actually in the legislation for the provider companies. In the new proposed legislation and regulations, it does not exist. And then other standards should be around access to culturally appropriate, more than that, culturally sound services. Sorry, I'm trying to think of the correct word. Compassionate care, equity in terms of care, and so on.
Thank you very much for your answer. And I just want to sort of respond to one of my colleagues, just in case they may have misunderstood what I said, that I think we should be debating public and private care here. There was no, in my remarks, I think it's important that we do. That's an important debate. And the thing I think is really critical right now that's missing in this legislation is that we need the public-facing part of it, the governance, the ability, the clear, the enshrinement of rights around governance, around your rights to appeal, and having clear access are not in there, and it's just kind of, it's all on good faith. So I just want to ask Ms. Mehra again. So I realize that you want to withdraw this legislation. I think you're right. I think it's something we should at least take a pause at what we're doing right now, because we're in the middle of a pandemic. So in terms of the things that really are critical to be enshrined in the legislation, what do you believe those things are?
Well, the definitions of what the legislation covers should be in the legislation, not in regulations. The rights of clients should be in the legislation. The powers of the minister to disapprove of agencies based on their compliance with the Bill of Rights, based on their financial soundness of operation, based on their record of operation, on the soundness of their premises. All of those protections that have been pulled out came out of decades of advocacy for improvements. The level of care that's actually provided must be in legislation. If anyone was to create another tier of congregate care, that would need to be in legislation with all of the attendant protections that people need when they live in those places. And I think we have, learned, hopefully, will have learned the lessons of COVID regarding that. The rights for complaints. What is a complaint? What isn't a complaint? How you do it. The rights to access information. There should be governance. There should be public oversight. I mean, just the entire structure is gone. And there is nothing there.
Thank you very much.
I'm sorry, I'm shocked at that.
Okay. Thank you very much. I don't know if either of the, Mr. Aberley or would like to make a comment on that, or Ms. Kennedy. Put your hand up.
I'll make a very brief comment. I think there are areas that it makes sense to have private corporations in. I think there's areas that it makes sense not to have them in. It makes no sense, as far as I can see, in the healthcare sector generally, to have private for-profit companies. And I just think that's one sector that should not have for-profit corporations.
Thank you.
Yes, I agree with that. And I think the government member has mentioned several times over the last couple of days that this bill hasn't been amended in 25 years. Well, 25 years ago, the private sector was only 18%.
2 minutes.
Of community and health and home care services. They were providing only 18%. I think that's a good place to start and go backwards from there in terms of taking out the profit margin from our looking after our seniors and our disabled in this province.
Thank you very much. I'd like to thank all the presenters again for taking the time and your great presentations and your comments. Appreciate it very much. Thank you.
Thank you very much. Now we are going to move to the opposition side. May I know who is speaking from the opposition side? Madame Jelena, please go ahead.
Thank you. The reason for the bill is because our home care system is broken. It fails more people than it helps. It doesn't meet the needs. If you had to tell me what are the top 3 things that would really go at fixing our home care system, what would it be? And I will go backward this time from Natalie to Mrs. Kennedy to Mr. Aberley. Mrs. Mehra.
Thank you very much. Fundamentally, home care in the new system proposed and in the existing system is fragmented. There are 14,000 different billing codes. There's hundreds of agencies. There's all kinds of duplication at every level. All of that was created because of the desire to bring in the for-profits and contract out home care. None of it would be necessary without that. To get money to care, looking at what's happening right now, the markup, according to the Auditor General's report, the 2015 special audit of the CCACs, the companies are charging between $58 and $70 for nursing care an hour, $29 to $48, $49 for PSW care. Nurses in home care might get $30 an hour. PSWs might get $15, $17 an hour. I mean, the markups are extraordinary. All of that public money is being siphoned off for profit. In addition to that, there's multiple duplicate administrations at that level. Then there's the tier above and so on. This new system actually makes that worse. It fragments care even more, and it takes away all governance. So it just says, here, provider companies, have at it. Divvy up home care how you want. That is not acceptable. The way that a Home Care Act, if it was to be reformed, should happen is that there needs to be strengthened public governance, strengthened clarity around standards, strengthened equity in the provision of service, less tiers of administration, much more of a public, not-for-profit home care service where the money goes directly to the actual providers of the service. I think in the last session you heard from PSWs on the front line. I mean, they get the last tier of money after it's gone through umpteen tiers, and that wouldn't change under this legislation. There are no additional protections for access to care, no additional protections for people who have missed visits, which is very, very common, for the staffing shortages. Those things would need to be addressed in new legislation that actually shunts the existing public money to home care and then improves funding and improves the requirement to provide care based on people's needs.
Thank you. That's more than 3, but it's very good. Mrs. Kennedy.
Yes, I agree with Natalie and the position of the Ontario Health Coalition, but I also think that we need to start over. We have a system that is broken, but if you look at a system that is publicly managed and one system, it's a public healthcare system that also does community and home care. You eliminate immediately millions of dollars, number one, that has gone to private corporations, and more millions of dollars that are in separate administrations of all the different private companies that are in the business. I think that there are savings, and those savings deserve to be invested in the people that are actually providing the work. I think that it is time that we made amends. If we continue with this same system, we will have PSWs who will still be underpaid and struggling to survive. And that is not acceptable. It is not acceptable, especially because in the major cities, they are Black and racialized women who are at the bottom of the pile. And we need to address these concerns in how we deliver our community and home care.
Thank you. Larry. You're mute, Larry.
Yes.
You're getting better.
I'm getting better. Good. First of all, I agree that they're with the previous speakers, but I think specifically for my members, they want independence. So I think it has to be an ease of access of how they can get this care. It has to be some way that they can
2 minutes
and know that they're getting a competent, and quite frankly, they got to know that they're getting the appropriate care. I have seen, in some cases, what I would call cognitive decline in some people. I worked with a lot of these people for 30 plus years, so I can remember them in the past and not now. Some of them have trouble dealing with the system as it is, and they may have family members that help them, they may not. And somehow we got to make it easier to get them and allow them some independence, and yet you've also got to protect them, because, and that's a balancing act you're going to have to kind of work through.
All good. Joel, if not much time, but if you want a closing comment, go ahead in the closing comment for MPP Hardin.
Well,
MPP
only to
Joe
thank all
Hardin.
my friends, Larry, Helen, and Natalie. Nice to see you weighing in. And what I've heard, certainly loud and clear from all of you, is that we need to make sure the people on the front lines are given the support and all the public funding they deserve. So I take that absolutely to heart. I hope it wouldn't surprise you, just to read into the record, that some of the folks participating in this debate are part of political parties that have taken big donations from for-profit operators. So I just want you to know that that part of the conversation is going to be on the record in the months going ahead. And I hope my friends in government are going to stop taking the advice of the wrong people. Thanks.
Thank you very much to the opposition members. We are going to move to the government side. MPP Martin.
Thank you very much, Chair, and thanks again for your comments. I've been listening with interest, and I do want to just correct on the record, first of all, I am entitled to ask a yes or no question, and I appreciate you giving a yes or no answer when I do. That's the way we control the time, and so I appreciate the fact that Larry did that. Thank you very much, Larry. And, you know, I think that that's how we also get answers to the questions. I know my colleagues have used that method as well to make sure that they can ask the questions that they would like to ask. Secondly, the regulations were posted on the regulatory registry on February 14th. So contrary to what Ms. Mehra had indicated, they were not posted during the lockdown. That started on the 17th or 18th of March. So there was a full month when they were posted before that time, and were not pulled down until April 14th. And I also wanted to just comment that, unfortunately, Ms. Mehra, I think you have misread the section on private hospitals. The amendment to the Private Hospital Act, I'm a lawyer, by the way, so I've checked it again. The amendment to the Private Hospitals Act is specifically drafted to exempt residential congregate care models, once defined in regulation, from this act. And these models are not intended to be private hospitals. We want to make sure that they're not accidentally captured as private hospitals. And that is the reason that we drafted the amendment that we did to the Private Hospitals Act, which is exactly the opposite of the interpretation that you proffered. So that's all, Chair. We don't have any further questions for these witnesses.
Thank you very much. Thank you to all the presenters for the 3 p.m. Group. Thank you. Do we have the next presenters?